So good afternoon, and thank you very much to Insigneo for the invitation to talk today. I'm going to talk to you about selenium and bone. And I'm going to show you some of the chemistry, some of the biology. I'm going to try to persuade you that the evidence suggests that selenium does have a role in the physiology of bone, and then I'll tell you about the clinical trial that's ongoing at the moment. So selenium is located number 34 in the periodic table. And for fans of chemistry trivia who like to be armed for the Family University Challenge, join in. It's named for the moon, Selene, and it was discovered in 1817. And the discoverer noticed that it had similarities to tellurium, the element below, which is named for the Earth. So he named the new element for the moon. It's actually a fairly ubiquitous presence in quite a lot of minerals, and it has commercial uses. In glass making. It's got a slightly red tint, so it's used to kind of take the green tint out of glass, and in some electronics as well. And selenium is a fairly ubiquitous nutrient. It's in pretty much everything we eat. It's in cereal, it's in animal protein, it's in vegetables, it's in nuts. But the amount of selenium we get in our diet depends a lot on the selenium content of where our food is grown. And that's quite variable around the world. So you can see here there's quite a large geographic variation in selenium intake and selenium status. So in northern USA and across the middle of Asia, selenium status is quite good. But in Europe, actually, we get less selenium in our diet than the recommended intake. And so as a population, we probably are a bit chronically selenium deficient. Why does it matter? Are you worried about this? Well, there is observational data correlating all-cause mortality with serum selenium. And so this is data from the USA. Remember, that's quite a selenium-rich population. And you can see this is the distribution of serum selenium in the population. And if you overlay an all-cause mortality curve onto that, there seems to be an optimum serum selenium level for minimum mortality. And that seems to be somewhere between about 120 and 150 micrograms per litre. So if we then superimpose on that the UK distribution of serum selenium from the UK NDNS survey, it's over here. So actually, the peak serum selenium in the UK is well below that optimal range. And to have a serum selenium of about 120 micrograms per litre in the UK is quite a long way above the national average. So there are data from other data sets to show associations between selenium and mortality. This has been shown in a number of countries, but obviously for the audience today, I've chosen the Italian data set. And you can see that based on quartile of serum selenium, there's a clear association with survival. So why might that be? What does it do? Well, there are about 25 known human selenoproteins. Some of them have important roles in thyroid metabolism, but quite a lot of those with identified function are antioxidants. And they have a kind of common factor, and with a cysteine residue. But you can see there's a large number of proteins which have been identified as human antioxidants. And they act as antioxidants through a kind of whole range of mechanisms, really. Some of them catalyse the breakdown of hydrogen peroxide, that's glutathione peroxidase, and that's probably kind of the best described antioxidant selenoprotein. They also bind metal ions and so prevent generation of reactive oxygen species, which we think of as kind of inflammatory baddies. And they scavenge free radicals. So all of these things should have positive effects on the kind of pro-oxidant environment that we think of as a common pathology in quite a lot of the diseases of aging. So why does it matter for bone? Well, it may be that those reactive oxygen species are a part of the fundamental pathology of osteoporosis. We know that after the menopause, loss of estrogen is probably the most important factor in losing bone and osteoporosis. And reactive oxygen species are part of that pathway. When estrogen is removed, then the presence of reactive oxygen species drives bone resorption and osteoclast activity. So it's possible that if we could find an intervention which stops that pathway, we could be directly blocking the pathway through which estrogen deficiency leads to osteoporosis. So that's kind of theoretical model. Does it work in practice? Well, it works in mice. So in mice, given a selenium deficient diet, we see adverse features on bone. So we see reduced trabecular volume, reduced trabecular number, greater trabecular separation, and reduced trabecular connectivity. And all of these are important factors for bone strength. And then if you feed your mice a selenium-rich bean diet, you see the converse, you improve bone structural properties. So potentially, yes, it could work in vivo. What about in humans? Well, we have some observational data. The OPUS study was a study of osteoporosis across 5 centres in Europe. And this was a secondary analysis once we got interested in this idea. But we did find that serum selenium was associated with bone turnover. So higher serum selenium and higher serum selenoprotein P were both associated with lower bone turnover, which we would expect to be protective and reduce the risk of osteoporosis. So we have in vitro ideas, we have some in vivo animal data, we have some observational human data that selenium might be important for bone. So the next step really is to go on and do the clinical trial and see if it really does work. So we are conducting a study of selenium supplementation in older women. And it's a randomized double-blind controlled trial. And there are 3 treatment groups. There's 200 micrograms of serum selenium, which is probably a slightly supraphysiological dose, 50 micrograms, which is about the recommended dietary intake, and placebo. And we're administering that as sodium selenite. The participants are postmenopausal women who have an osteopenic or borderline osteoporotic T-score, and the target recruitment was 120. They are taking the selenium for 6 months, and the primary endpoint which we've chosen is urinary NTX, and that's a marker of bone resorption. And the reason we chose that particular marker as the primary endpoint is in our previous observational data from the OPUS study, that was the marker with the strongest association with selenium status. And then our secondary endpoints are serum selenium, selenoprotein P, all the other bone markers that we use as standards across all clinical trials, so that's P1NP, osteocalcin, and CTX. We're also assessing whether there could be effects on muscle function, and we're doing that with a short physical performance battery, which is a standardized test involving sitting up and standing down, standing with your feet in parallel and walking a 6-meter walk test. We're measuring grip strength. And then to try and get a bit of mechanism, we're measuring some of the antioxidant activity, so glutathione peroxidase and hydroperoxidases. We're also assessing some inflammatory markers with interleukin-6 and highly sensitive CRP to test the idea that this is all about kind of a chronic inflammatory milieu. So we have now recruited all of the participants into the study. The first one came and started the study a couple of weeks ago. And these are the baseline serum selenium levels of the women who've entered into the study. And so, as you can remember, they are fairly representative of what we would expect to see in a UK population. Everybody is below that level of 120 that we think is probably associated with better health, and some of them are really quite low. And it was a bit of a relief to see this, because when you recruit to a clinical trial, the sorts of people who volunteer to come and be in a clinical trial are more healthy than the average population. And we did a study of vitamin D last year, and we all know that the UK population are vitamin D deficient pretty much all the time, but the sorts of people that volunteer to come on studies are very health conscious and take their vitamin D and do all the healthy things, so actually finding people that were deficient was a real challenge. But this population looks as we would expect, and this means that if we do show that selenium works, we hope that we can say that it's going to be applicable generally across the UK population. So in summary, the European population is relatively selenium deficient. There is a biologically plausible mechanism that it could be beneficial for bone. We have preclinical and observational human evidence. The proper randomized controlled trial is underway now, and we would expect to have the results available early next year. And if we do show that selenium reduces bone turnover and could potentially be beneficial for bone, then that's the stage at which in silico medicine can help us to try and model some of those mechanisms and understand if it is really acting in the way that we think it might. And also by extrapolating our surrogate endpoint of bone turnover into what that might mean for bone density and potentially fracture risk down the line. I would like to acknowledge all of our collaborators that are working on this project together. Thank you very much.
Lovely talk. I've got a question about what is understood about selenium absorption.
In terms of its GI absorption and factors that might affect that, not very much that I know of. In terms, if you look at kind of the normative nutritional data for selenium, it's based on not very much experimental data, and most of it's based on kind of population observational data. So if you go away and look at kind of things like the recommended daily intake, you actually see it's a really, really broad range because the understanding of its physiology has not been studied that well. We are collecting, as part of the study, we asked patients to fill in a 7-day diet diary of absolutely everything they eat and drink for the first week and the last week in the study. And that will allow us to do a bit of exploratory analysis with dietary cofactors to find out if selenium might work best, see if you also have a good dietary calcium intake or other factors like protein intake. So we will be able to dig into that a little bit.
Jenny? Yeah. So if I understood correctly, you've got 3 groups, so one without added selenium, one with 50 and 120. I'm wondering whether your baseline data is not going to skew a little bit your results in the sense that if you have someone who's very low selenium and you give it 120, you're just bringing that person to a normal level, let's say. So would that not change your results, depending on how you're sorting your cohort?
Yeah, it may be. It's randomised, so we would anticipate that the spread of people who get each dose should be representative across the whole population that we've recruited. And we will do that as an exploratory analysis as well to see whether baseline serum selenium affects response and whether the magnitude of change is what's important. We think the dose of 200 should increase serum selenium by about 100 micrograms per litre, so it should be enough to take you, even if you're low, quite comfortably into that optimal range. So within the kind of range of our baseline, we think at the higher dose, we should get everybody well into the optimum range, and then the 50 dose is just to find out if that might actually be enough. Thank you.